Thanks, Ben. Obviously, there's a lot of people involved in this work. For those of you who don't understand much of the high-powered statistics we've been talking about already, you'll be pleased to know there's very little statistics in this talk. So this is some work that's currently ongoing, but we presented at the SCTS meeting in January, and it's looking at combining the UK cardiac surgical database with the UK TAVI registry. And these were some of the goals of this work, looking at what's been happening to our surgical practice in the TAVI era, how the number of TAVI cases increased, how do the patient populations undergoing TAVI and conventional surgery compare. We wanted to look at comparative outcomes of these groups. We also tried to think of some way of comparing the groups, and people who understand statistics more than me felt that things like propensity analyses were not valid. And so we took a very simple concept of just looking at patients who are over the age of 80 having conventional surgery. And then we also looked at existing risk stratification models in their ability to predict risk for surgery and TAVI. So this talk relates to prospectively collected data for all aortic valve interventions, excluding balloon valvuloplasty, performed in the UK between the dates on this slide. When we set up the UK TAVI registry, we were careful to make sure the data set and the definitions were comparable to the surgical data set and definitions, so that these registries and databases would be comparable. And so these data are extracted from these two databases or registries. The conventional surgery was further subdivided into three groups: patients having isolated AVR, patients having aortic valve replacement and concomitant coronary artery surgery. And there was a third group, which was a really rather heterogeneous group, where aortic valve replacement was combined with other procedures, mitral valve replacement, and other such activities. And these are the numbers of interventions in these various groups over this 5-year period. And for the remainder of the talk, sorry, we don't seem to have a, does anybody know how this works? Ah, there we go. We looked at this, or Ben and Graham looked at this, and this group is extremely heterogeneous, and we felt that many of the patients in this group really would not be TAVI candidates. So we've concentrated on these three groups: isolated AVR, AVR and CABG, and the emerging TAVI population. What's happened with TAVI? Started in the UK in 2007, steady growth. In 2011 and 12, there are about between 1,000 and 1,100 cases. Looking at all surgical aortic valve interventions, you see that there has been a growth, but this seems to have plateaued from about 2008 onwards. So this steady growth that we've seen in surgical AVR seems to have plateaued in the last 2 to 3 years. What about all aortic valve interventions? We see during this period of 5 years, there's been nearly a 30% increase in all aortic valve interventions occurring in the UK. What about in those over 80 years of age? And you see here that the number of interventions in patients over 80 has approximately doubled in the last 5 years. And if you look at this, about half of that increase has been due to an increase in conventional surgery, and about half due to the emergence of TAVI. By 2010, 9% of all aortic valve interventions were by TAVI in the UK. If you include that third group of AVR plus all the others, it still comes out at 7%. So a significant number of aortic valve interventions are occurring by a catheter-based approach in the UK. What about the patient populations? I don't think there's a great surprise here. You'll see that the TAVI patients are older, and they have much greater prevalence of comorbidities than those undergoing conventional surgery. Perhaps one thing to note, a relatively low proportion of females having isolated aortic valve replacement. Interestingly, no real difference in the proportion of patients with low ejection fraction across the three groups. Note down here that TAVI still really is an elective procedure. There's not a lot of emergency or non-elective TAVIs being performed. In the population over aged 80, not surprisingly, the age groups are the same. Quite a marked difference in the proportion of females undergoing isolated AVR, but the rest of the categories are very similar. Just highlighting perhaps one of the biggest differences both in all populations, in all patients and in the over 80-year-olds, the dramatic increased prevalence of significant renal dysfunction in patients undergoing TAVI to conventional surgery. Looking at the distribution of patient age, you see the TAVI population is older, but you see there's really quite a large overlap between these two distributions. And similarly, looking at the logistic Euroscore, which I'd perhaps like to sort of reflect the prevalence of comorbidities rather than calling it a risk score in these patients. But again, still a big overlap, although obviously much a higher median number in the TAVI population. We're also able to look at post-operative stay. So you've seen the TAVI patients are older, they've got a greater number of comorbidities, and despite that, there was no difference in average hospital stay between these two populations. And if anything, the TAVI population had a lower length of stay. And I think this is a very interesting and important observation, perhaps particularly when we look at more elderly patients. And this is just a different way of looking at that. And you can see here are the TAVI population, and you can see quite large numbers of these patients going home before day 5 after their intervention, which clearly is, not surprisingly, absent in the surgical group. I'll skip that slide. Clearly, sort of high mortality in the early days with TAVI. This seems to have plattered out at about 5 to 6% 30-day mortality following TAVI in the UK. Not surprisingly, TAVI outcomes significantly worse. This finding is pretty consistent in all the UK and North American data that isolated AVR does better than AVR and CABG. We looked at a bit more detail at what happened in the first year, patterns of mortality, and you see most of the difference here is occurring in the first 90 days. I think this is an interesting slide, sort of preliminary data, but looking at patients over the age of 80, and you start seeing really that the outcomes between TAVI and patients having AVR and CABG are not very dissimilar over the first year after the intervention. Finally, just moving on to risk model performance. I think you're all aware of how these things are compared. And I think if you look here, if you look at the original logistic Euroscore, you can see that the observed to expected ratios for TAVI, isolated AVR, AVR and CABG are not good, and that's also reflected in the area under the curve. Euroscore 2 performs really quite well in the conventional surgery group in terms of observed versus expected, but does not perform well in the TAVI population. So, to summarize this piece of work, which is ongoing, and we are hopefully about to update this with the 2011 data, I think the strength of these registries compared to many others around the world is that they are publicly funded and therefore are free from any commercial bias. They're also free from selection bias because they're not voluntary. There's robust independent long-term tracking, and as I've said, the data sets and definitions in these registries are comparable. There's been a significant growth in all aortic valve interventions. Half of this increase in growth has occurred in octogenarians. Predictably large difference in demographics with patients coming to TAVI being older and at higher risk or with more comorbidities, although there's a significant overlap between the group. Despite this, interestingly, median postoperative length of stay was similar in both cohorts. And a final comment about the scores. Logistic Euroscore does not predict outcomes for surgery or TAVI. Euroscore 2 tends to give good prediction for conventional surgery, but still does not have a satisfactory discriminatory ability for predicting mortality outcomes for TAVI. So we're still struggling to look for appropriate scoring systems in this population. Thank you very much.